Hello, I'm Dr. Maureen Markman from City of Hope, and I'd like to discuss in this session and the next two what I consider to be a very interesting, a little bit of a complex, but I believe a really important topic. It is certainly very well recognized that there are multiple factors that influence outcomes, and specifically survival in individuals diagnosed with malignancy. This, of course, includes the tumor type, lung cancer, breast cancer, etc., the histological subtype, adenocarcinoma, squamous carcinoma, as well as unique pathological features such as tumor grade, high grade, low grade, or increasingly, in fact, molecular biomarkers, for example, HER2 overexpression or estrogen overexpression, etc. Then, of course, there is the stage of the disease at diagnosis. And of course, we cannot leave out the effects on treatment, whether it's possible to remove a tumor surgically. What about the response to chemotherapy? How long that response lasts? Is it a full response? Is it a partial response, etc.? All of these are very important. And critically, we must add the relevant comorbidities. And I'll come back to this a few times. As cancer, of course, is not always, but is principally a disease of the elderly. And here, these comorbidities can have two very critical different effects. The first, of course, is the potential ability to undertake what we recognize to be optimal therapy. This would, for example, include the ability to undertake a surgery that might be curative for a particular malignancy, or conversely, the ability to actually deliver any therapy at all. And in fact, you might give effective treatment, but in fact, it is the comorbidity, heart disease, for example, and very specifically often that causes an individual's death. So it's the impact of the treatment for the cancer, and then its own impact on survival. And of course, we need to add those actions that an individual patient may be able to and elect to undertake that can impact their outcomes after the diagnosis. For example, stopping cigarette smoking, or increasingly we are seeing evidence that exercise can have an impact on the risk of recurrence, for example, in survival. But what I want to cover briefly right now, and then the next two sections, is the absolutely critical role of clinical judgment in the care of individual patients, and the role of clinical judgment in optimizing survival for that individual patient, but also the potential impact that this factor may have in creating a bias when an investigator or even an institution subsequently attempts to analyze the survival of a population of cancer patients managed by the same group of excellent clinicians. More to come on this topic on the next segment, and I thank you for your attention.